Thank you very much, Helen, and it's great to see you all here. Thank you for joining us today. This talk is going to feed into my next talk later on today about complex pediatric transplantation, as there's some overlap, obviously. So we've heard a bit about preparation for transplantation from the medical side. I'm going to concentrate mostly on the surgical side, even though we heard a lot already on the urology side. I'll speak a bit about that, as well as other surgical aspects, vascular considerations, coagulation, as well as what we do when the child is very small in comparison to the kidney he or she is receiving. I'm glad this paper was not shown before, but essentially we had previously, a few years ago now, reviewed the different procedures and interventions we've done in urology in patients with lower urinary tract dysfunction, and whether we've done that before or after transplantation. So we had, in the period of 8 years, 288 transplants, and 77 of these were in 75 children with lower urinary tract dysfunction. The majority of those, as you can see here, were from children with posterior urethral valves, and 46 received an intervention, and we've heard a lot about interventions in the previous talk. So the majority seem to be bladder augmentations with Mitrofanov in some 37% of the cases. And as you heard, it does depend a lot on if the patient is able to produce urine and keep essentially self-cycling the bladder. Now, the majority of these were pre-transplantation. Obviously, these kids were passing a lot of urine. And the outcomes of these, whether they had the intervention before or after transplantation, were similar with respect to graft survival, as you can see here, 95, 100% respectively. And you've already seen much better pictures than this. This is creating the new bladder using dilated ureters. And this picture shows using small bowel in this particular case to create the augment. This is a picture of a Mitrofanov, and also looking at it from the surgical and the transplant side, seems to be in the place where you want to put your transplant, isn't it? Most of the time, you can actually create your incision just below that and push everything upwards extraperitoneally. But that's how it looks. And the majority are on the right side because most kids will be right-handed, and that's why it's there. Sometimes you use the left side. And it depends also from which hospital you work at, and maybe through the umbilicus as well. And when you run out of options pre-transplantation, as Imran showed before, you can do a cutaneous uterostomy, and that's how it looks. But many of those do end up stenosing, so they're not without their own complications, let's say. So we'll always involve the urology team pre-transplantation. We can also discuss potential sites for the Mitrofanov as well. As I mentioned before, right side or umbilicus, for example. And we've heard a lot about making the bladder safe, and we want a low pressure, compliant, sterile, and a decent reservoir before transplanting, and also continence. Actually, Imran is always very helpful. He says, if you need to move the Mitrofanov during your transplant, let me know and I'll move it for you. We've never had to do that, but it's always good to have some support if you need to. We tend to do a midline incision for the smaller kids, and I'll talk more about small kids later on. And you can use a midline approach to create the to do your transplant and bladder anastomosis in the cases of Mitrofanov or augmented bladder, or you can use the retroperitoneal approach. And of course, retroperitoneally, you can avoid adhesions as well. Occasionally, we need to remove one of the native kidneys, or even more rarely, both. We are guided by the urology team, nephrology team, as well as the patient choice sometimes with respect to that. It's about 1 in 800 where you get 2 ureters where you might need to reconstruct them, join them together. We tend to put them separately. Could also use the native ureter. I'll talk a bit about unblocks later on. We use the Leach-Gregoire technique, and we'll always use a stent that stays in place for about 4 to 6 weeks. Previous surgery is important, as there might be adhesions, and it might take a lot longer to do the surgery. Depending on the situation, consider starting the recipient first to make sure it's feasible before a living donor nephrectomy. If they've had previous transplants, like a liver transplant, you can always either do a retroperitoneal approach, or if you could do a midline, just inform the liver team in case you need some help with the mobilization of the liver to achieve enough space for transplantation. Also, for the smaller ones, we do have a second colic at hand for extra help. This day and age, kids come in all different sizes. It's not just adults. And of course, if a child is obese, it takes longer to do the procedure. The risks are high with respect to wound problems. Also, there's a bit more risk of delayed graft function, especially if it's in disease donation. Vascular considerations, we may have multiple arteries, and we'll hear more about that later on. But essentially, we try to utilize all the arteries that we have. We may need to do some reconstruction with well-known strategies, as shown here. And small veins we can divide, and anastomosis veins myself. And we start with an ultrasound to assess the vascular anatomy, the iliacs as well as the aorta. And depending on the size of the child and how easy it is to do an ultrasound, we may do an MRI for the younger ones. If there are known vascular abnormalities, like no IVC and so on and so forth, we may do a CT venogram or a standard venogram. But we do less standard venograms these days. I'll show you a case of a 14-year-old. This was an Evelina patient, where we had the child on the deceased donor list for a second kidney transplant after losing the first one from rejection, and she was on hemodialysis prior to that. And you can see your heart sinks when you try to find a vessel to your anastomosis, and there's none really, or very little. So you need to look a bit more carefully. So this child had a left external iliac vein, which happily utilized at the time of the deceased donor transplant, with some heparinization at the time, with an excellent outcome. As we know, the smaller the child, the smaller the aorta as well, and we have a value of 10 kilograms, let's say, to start doing transplantation. Of course, this is a bit arbitrary. The main thing is to do your evaluation to assess if there's a big enough aorta for implantation, because sometimes you will encounter children with small aortas or mid-aortic syndrome, or that were not detected before, or aortas that were split higher up in the abdomen, and therefore you have only the common iliacs to anastomosis. Blood pressure is of an issue, as you all know. You ask any surgeon when the good blood pressure at the time of surgery. We'll hear more about that from our eminent anesthetic team. And so that's an issue that we do encounter very often, especially in the small children, and of course, occasionally we get caught out because the donor kidney comes with a history of hypertension, sometimes multiple antihypertensives, and we don't see the effects until we transplant the child. And I remember one particular case, small recipient, GOS this time. We took a time zero biopsy after it took a bit of time to become pink, and all the arteries were were sort of obliterated really from the hypertensive disease. So I wasn't sure how I was getting his blood supply, but anyway, it did last for about a year, that particular kidney, or a bit more. Now, we don't routinely screen from thrombophilia ourselves, but in this European Society for Pediatric Nephrology survey, some 94% of transplant centers do screen for that. And this table gives the percentage of the units who actually give heparin. For example, those previous thromboembolic events, 87%, positive thrombophilia screen, 87%, small donor graft to a small recipient, 55%, and other venous or arterial abnormalities, 55%. We routinely give low-dose aspirin in our cohorts, both at the Velina and Great Ormond Street, based on this data where there's less graft thrombosis. Now, what about when there's a discrepancy between the donor and the recipient? Well, what is a small or a young child? We define, or this particular paper defines a small child, one that's less than 20 kilograms, this one less than 15 kilograms, this one less than 11 kilograms. So there's no precise definition. We tend to call a small child one that's less than 20 kilograms in our hospitals. And the main reason for that is because we do an intra-abdominal transplant if it's less than 20, as opposed to extraperitoneal, even though that definition has become more blurred recently as we do more extraperitoneal transplants in the ones saline that are between 15 and 20. Anyway, we reviewed our data, less than 20 and more than 20 kilograms, to see if there's any changes in graft survival. And you can see 123 in the less than 20 and 330 in the more than 20, and there was no significant difference between these two groups of patients. So we talked a bit about investigations, specialist reviews before they come to see us in clinic, and then sometimes they go back for further investigations and so on, and come back to us again in clinic. I think it's always good to see them often to make sure you also obtain a good consent as well. And eventually they'll pass through our MDM before we formally consent them and do their transplant surgery. Thank you very much. Take the opportunity for some fluid management. Yes, thank you. Albumin.
How do you prepare them, especially if somebody's got nephrotic syndrome and high chance of recurrence?
Well, obviously we prefer it to be, I guess, in the 30s, but I rely a lot on my nephrology colleagues. And I guess also from the thromboprophylaxis point of view, also that's a risk. I guess we don't worry so much about the albumin because most of the time it's fine. We occasionally worry about ureas, and that's would have been a much bigger discussion. Yes, thank you.
I was just going to add that we normally, like Nico said, don't really look at the albumins anymore, but we do try and get them in the 30s. The fact that their urine output is reducing is indicative by the fact that their albumin starts to rise. So you can see that. And for the nephrotic children, for the genetic positive ones, we don't really do the nephrectomies anymore. And for the patients who don't have a genetic variant, we tend to nephrectomize only if their coagulation is abnormal or they have a really good urine output, or albumin is usually not an indicator. I can remember one in the high 20s that we've recently done and has been fine. So we just look at the overall picture and try and do that.
Yes, thank you, Zaina. That's a good question.
Any more questions? Steve?
I just wanted to touch on, you talked about the size of the patient being weight, but surely the important thing is the length of the child, because you're wanting to know about the vessels. So is there a way that we should be thinking about the vessel? Maybe tell the audience what your minimum vessel size is. How many millimeters on ultrasound or MR?
Yeah, we prefer the aorta to be more than 4 millimeters, I would say, ideally 5. I guess, yeah, we need to tailor to the patient to take the whole picture into consideration. Of course, you can always do and transplant on a younger child if you have a smaller kidney. And indeed, if you look at the literature that's been coming from China the last 5-10 years, they do a lot of that. So they actually send all the young, small donors, let's say, into the pediatric recipient, and even under 1 year of age. And occasionally we see, for example, Walter, who's going to join us tomorrow. Unfortunately, couldn't make it in person, but he transplanted a small kidney into a 5-kilogram recipient when he was in Stanford. So it is possible. It's just we don't have many of those kidneys, unfortunately. Yeah.